My name is Peter Barany. I'm a nephrologist at the Karolinska University Hospital in Stockholm, and my talk is about updates on management of renal vasculitis. Since 2012, we have the international nomenclature of vasculitis, and what we are discussing today is ANCA-associated vasculitis. The three forms is microscopic polyangiitis, granulomatous polyangiitis, and eosinophilic granulomatous polyangiitis. But I will only speak about the two first, microscopic polyangiitis and granulomatous polyangiitis, which is a small vessel vasculitis. A few words about the pathogenetic mechanism. It's not clear exactly what happens in the cell, but there is some theories that we have a loss of gene silencing and the chromatin modification and the changes in the DNA methylation of the DNA, which results in higher MPO and PR3 expression. Normally, the neutrophil has expression of both MPO and PR3 on the cell surface, but in low amounts. But with some trigger, it can possibly be infection or inflammatory stress of any kind, or also complement activation. It activates the neutrophil, and then we have a much more intense expression of MPO and PR3 on the cell surface. And with that, you can also see formation of antibodies, ANCA, the ANCA formation, and this results in a cascade of effects on activating more and more neutrophils. And with this recruitment of new neutrophils, you have also the attack on the endothelium, and these neutrophils forms what is called neutrophil extracellular traps. And we have complement activation in several steps, and the inflammation and the vasculitis progress. And late you have granuloma formation, at least in the granulomatous polyangiitis. Global incidence, we have scarce information of that. This is in Sweden, where it is 20 patients per million population per year as incidence. We have no information in the Arabic or Africa part of the world, only this Bethlehem West Bank, where is lower incidence of ANCA vasculitis, according to this paper. Genetics are also involved, but we have very little knowledge how, but there are genetically distinct subsets. So this is MPO, a positive ANCA, where you have a subset of MHC locus genes which are activated, and there are different genes activated in PR3 positive ANCA. And there's overlap between the clinical pictures. We have the renal limited with no or only minor systemic signs of vasculitis, which is often also called post-immune crescentic glomerulonephritis. Microscopic polyangiitis is overlap between the MPO ANCA and PR3, and GPA granulomatous polyangiitis. There is also some overlap, but more PR3 positive patients here. And this is also the typical organ involvement in this GPA. You have more involvement of the upper airways and sinusitis and the ear, nose, ENT involvement. And also you can have pulmonary nodules and also cavitary lesions in the lungs, and of course renal disease. And this is mostly PR3 positive. MPO is less than 20% in this entity. Microscopic polyangiitis, more renal disease and less involvement of the lungs, but there can be infiltrates. And this is mostly MPO, but PR3 can be up to 30% here also, and more ANCA negative vasculitis here also. So, and the frequency of organ involvement is shown here, where you have 90% kidney involvement in microscopic polyangiitis, pulmonary 50%, ENT 35%, etc. And GPA 80% kidney and 90% pulmonary involvement, also ENT 90%. eGPA is less kidney involvement, more pulmonary and neurologic involvement, and also cutaneous. The BVAS, Birmingham Vasculitis Activity Score from 2003. It's good to look at that sometimes, and also for students and young doctors, it's good to look and to score vasculitis patients, how many scores and how many organs are involved in this disease. So renal, there is a lot of extra scoring, grading for renal involvement, which is the most common and severe organ involvement in the disease. So when we have a patient, the patient present for nephrologists, at least with rapid decline in kidney function. Of course, there are other presentations with long-standing ENT symptoms or pulmonary infiltrates, but this is when you have a kidney dysfunction, when you have observed kidney dysfunction, and you look at the urine dipstick, usually positive for both protein and blood. You can look at the sediment. It is not very specific, but you also have hematuria and some leukocytes or neutrophils in the sediment also. And then with this rapid decline and urinary findings, you consider a rapidly progressive glomerulonephritis. And then you have to evaluate for other diseases, SLE and anti-GBM antibodies, and check for ANCA antibodies. And complement if there is a C3 nephropathy, for instance. But also exclude infection, which is very important. And plan for a kidney biopsy. This is a list where ANCA testing is recommended. It's not recommended to take ANCA on all patients with renal disease. Then you will have more unspecific ANCA positive patients, which makes more, it will be less specific test. But if you have a suspicion of glomerulonephritis with proteinuria and rapidly progressive glomerulonephritis. If you have lung involvement, you have cutaneous vasculitis, lung nodules, and the destructive disease of the upper airways, long-standing sinusitis or otitis which not respond to antibiotics, and also tracheal stenosis. Mononephritis is another which can be long-standing symptom, and retroorbital mass rarely, but it happens that the patient comes to the ophthalmology list, and also for long-standing scleritis. ANCA testing has been developed during the last 30 years. It was discovered in 1982 that ANCA was associated with glomerulonephritis and later to GPA and ANCA vasculitis. And the testing and the methods have been more and more precise and more have good specificity and sensitivity, as we see here. It's very sensitive and very specific testing if you take the test on indication. It's better than immunofluorescence, and it's recommended as the method of choice today to have a immunoassay, a modern immunoassay for ANCA testing. So you should have this gating policy and which patients you choose to test for ANCA. You should have a modern high-quality antigen-specific assay. If both PR3 and MPO ANCA tests are negative, and you have a strong suspicion, then it's recommended to use another immunoassay or also immunofluorescence to repeat the test with that. And a negative test can't exclude an ANCA-associated vasculitis. And it's a contribution to the diagnostic workup and cannot be the only finding that is diagnosis for vasculitis. You should take into account antibody levels, even if they are not so specific for disease activity. So this is what you stepwise gating strategy. They should have a clinical suspicion of vasculitis, and then you have the immunoassays. And if you have a strong suspicion, you should have a second assay performed. And there are different methods. Direct ELISA is the most common method. We have as a second choice capture ELISA, which may be more sensitive in some cases at least. And then there's another method, anchor ELISA. I have no experience with that. So when you have a diagnosis, you should not wait for renal biopsy. You should start immunosuppressive treatment without delay. And when you have a positive ANCA testing, and most, I think, clinicians start with methylprednisolone, 7 to 50 milligram per kilo on 3 consecutive days. When you have a rapidly progressive glomerulonephritis. I think we are in the lower range, with around 7 milligram per kilo. We don't give the high dose 1 gram per day of methylprednisolone. And you should plan for the kidney biopsy, which is important for prognosis. Kidney biopsy, typical findings is a cellular crescents, and you count how many cellular crescents, and the other find is segmental fibrinoid necrosis. Then more chronic findings is a fibrotic crescent, and in many patients you find both active new fresh cellular crescents and fibrotic crescents, and also segmental sclerosis is more chronic changes. And the typical immunofluorescence should be palsy with just small signs of immune on the immune fluorescence. You can have some complement, but not very much. Arteritis we see rarely, but it happens that we have this is a interlobal artery. It happens occasionally that we have a clear arteritis with fibrinoid necrosis in the artery and leukocytoclastic infiltration and debris here. Pulmonary granuloma, rarely we take biopsies of the lung, but you can have granuloma, and you can see granuloma on CT scan or also on the radiological examinations. The extent of how much crescents and focal segmental changes you have, and also how many sclerotic glomeruli you have in the biopsy is important for the prognosis. So if you only have fibrinoid necrosis and very little crescents, then you have the best prognosis and more acute findings. Then you have crescents and mixed and sclerosis. The patient survival is also dependent on the kidney function. If you have less than 50 milliliters per minute, then the prognosis is much worse than if you have more than 50 milliliters per minute in GFR at the start. So then you have the choice of start treatment, mycophenolate mofetil, or when you have very limited disease, cyclophosphamide or rituximab based are the two major choices. And most think that if you have a very active disease, cyclophosphamide is first choice, but rituximab in more less severe disease. So this is what rituximab preferred maybe in children and adolescents and premenopausal women and frail older adults. But in severe disease where you have acute kidney failure, then cyclophosphamide is preferred. And there are the dosing regimens. We use this 50 milligram per kilogram 6 times every second week, the first 3, and then every 3rd week. Or you can use this rituximab. The old protocol is 4 times we did this dose, or you can give 1 gram two doses with 2 weeks interval. There are also combination protocols which has been used in some studies. PEXIVAS was the last study which evaluated plasma change, which found no effect of plasma change in this study. But you also evaluated reduced glucocorticoid dose, which was as effective as a standard dose. So now it is recommended to use a reduced protocol for corticosteroids. Prednisolone is here you have half the dose already after 2 weeks. So that's a rapid decrease in the doses of corticosteroids. Plasmapheresis still is used in severe kidney disease, when you have diffuse pulmonary hemorrhage, and also if you have the combination with anti-GBM antibodies. It's important to consider infections. Endocarditis may be the most important. You have to look for signs and symptoms, and also often check with echocardiography and take blood cultures, and you can see also in the kidney biopsy. Viral diseases and other chronic infections may mimic vasculitis and be ANCA positive. So this is a list where you have the percent of positive tests here, up to 45% in endocarditis are ANCA positive, and here 30% tuberculosis, and chronic hepatitis B here is in one study 30%, other viruses also rarely. Important to acknowledge the adverse events of immunosuppression, because mortality first years is more due to infections than to vasculitis activity. And the important risk factors is low GFR and if you have leukopenia. And long-term effects you have to consider: malignancy, cardiovascular effects, thromboembolic, kidney failure, of course, and infertility. And specific prophylactic measures is to have a protocol when you give infusions of cyclophosphamide and rituximab, sulfametaxol, TMP, sulfametaxols are given to all patients at least for 6 months, sometimes longer when you have rituximab. We use nystatin, and early we also use omeprazole. Calcium vitamin D, we don't use biphosphonates because of low kidney function. And also in vaccinations, although there are reports of vasculitis activity after vaccination, it's more risky with the infection than the vaccination. And there's a list of well-known corticosteroid side effects, and the rituximab side effects are listed here, and of course also cyclophosphamide, but with this short 3-month course of cyclophosphamide, there's not very much long-term effects of these doses. The prognosis is dependent on the baseline serum creatinine, but you have a good chance to recover most of the kidney function, even with advanced kidney failure. But the more you have from the start, the risk is higher to develop end-stage or kidney failure in the long run. And there is a list of which increase the relapse risk. This is PRT ANCA and GPA is more prone to relapse than MPA, and more extensive disease. If you have a previous history of relapse, there is a high risk, of course, ANCA positive at the end if you're not ANCA negative. And if you have less immunosuppression or early withdrawal of immunosuppression, there is a higher risk of relapse. The grumbling disease is difficult to balance ENT symptoms continuously, how to balance immunosuppression. And this is the difference in relapse risk between MPA and GPA in one study over 1 year only. So this is somewhat old protocols, so maybe not relevant for today, but higher risk with the GPA. And then for maintenance therapy after the first 3 to 6 months, you can choose rituximab now, or you can choose azathioprine. So there are some preference for rituximab with known relapsing disease and PRT ANCA, and frail older adults where you can have a glucocorticoid-sparing effect. And if you have a low hypogammaglobulinemia, then you can use azathioprine. So there are the dosing protocols every 6, 12, and 18 months, or there is another protocol every 4th month with rituximab and azathioprine 1.5 to 2 milligram per kilo. Finally, transplantation. You should wait for 6 months and have a complete clinical remission. And ANCA positive patients can be transplanted if you have a clinical remission. It can recur 2 to 3% per patient year in retrospective studies have a relapse after transplantation. The new treatment is avacopan, which is soon accepted and raised in Europe at least. It has less risk of relapse during the first year, but during the first year there was no difference in serious adverse events between prednisolone and avacopan. The long-term effect with corticoid sparing effects has not really been evaluated with avacopan yet. So that's the end of my talk. Thank you very much.